Welcome to this video entitled Constipation, Diarrhea, and Irritable Bowel Syndrome. Functional bowel disorders of the lower gastrointestinal (GI) tract can include symptoms of hypogastric cramping, abdominal pain, diarrhea, or constipation. Constipation and diarrhea can be self-limiting and are considered symptoms of possibly serious medical problems. Temporary dysfunctions of the bowel can include common gastrointestinal upsets that can cause diarrhea or short-lived episodes of constipation. One of the most puzzling functional bowel disorders is irritable bowel syndrome, IBS. Irritable bowel syndrome typically presents with vague, crampy hypogastric pain and can be accompanied by alternating constipation and diarrhea. Similar pharmacologic agents are used to treat these symptoms, whether self-limited or chronic. Let's now look at constipation. Constipation is a common gastrointestinal symptom that is defined as infrequent or difficult evacuation of stool. Every individual affected by constipation defines it differently, but normal defecation can vary from daily to 3 times a day or to every 3 days. Constipation can be a consequence of multiple factors, including diet, lifestyle, medications, and many disease states. In a systematic review of the epidemiology of constipation in North America by Higgins and Johansson, in 2004, the mean prevalence of constipation in the general population was found to be 12% to 19%. Constipation affects 2.2 females to 1 male, and the incidence increases with age, especially in those over age 65. Shah and colleagues in 2008 reports an increase of 4 million ambulatory care visits for constipation between 2001 and 2004. Of these 4 million visits, the highest increase was in children younger than age 14. Dietary and lifestyle modifications are the preferred therapy for constipation, but many patients use over-the-counter, abbreviated as OTC, laxatives for relief. Americans spend over $1 billion for more than 150 types of over-the-counter and prescription laxatives, Smith and colleagues in 2002, and according to Stessman in 2003. Most of these laxatives are considered safe and effective, but overuse or abuse may have serious consequences. We will now discuss the causes of constipation. Constipation may be initially diagnosed based on a thorough history and physical examination. If an identifiable cause is present, constipation is then classified as a secondary symptom. However, constipation may be a symptom of an underlying disease state, as shown in box 30.1. The patient's lifestyle, e.g., diet, inactivity, or concomitant medications, as shown in box 30.2, may also contribute to constipation. When no cause can be found for the symptoms of constipation, the disorder is categorized as idiopathic. Idiopathic constipation is usually caused by a reduction in the propulsive capacity of the colon, slow transit constipation, or a functional outlet. Although constipation is often a benign condition, it can be a symptom of a more serious problem. If left untreated in an elderly patient, constipation may lead to impaction, stercoral ulceration, anal fissures, megacolon, volvulus, and possibly carcinoma of the colon. Pause the video and carefully scrutinize box 30.1 summarizing disorders associated with constipation before proceeding to the next slide. Pause the video and carefully scrutinize box 30.2 summarizing selected medication associated with constipation and box 30.3 summarizing history and physical examination for chronic constipation before proceeding to the next slide. Next we will discuss the pathophysiology of constipation. The absorptive capacity and motility of the colon are major factors of bowel function. Approximately 9 liters of fluid enters the small intestine daily from ingestion or intestinal secretions. The small intestine absorbs approximately 80% of this fluid load, which is approximately half of its capacity. The colon absorbs the remainder, with the exception of approximately 0.1 liter of water that is passed in the stool. If absorption of the small intestine is reduced, the fluid load adds to the burden of the colon, which is capable of absorbing 4 to 5 liters of fluid per day. Fluid in excess of this amount results in diarrhea. Likewise, excessive reabsorption of water results in constipation. The colon can be divided into 3 distinctive functional areas. 1. The cecum and proximal colon. 2. The transverse colon. And 3. The distal colon and rectum. Each area performs different roles in preparing the chyme for expulsion. The variation in the neurogenic tone of each area affects the capacity of the colon to retain or release the fecal material. The motility of the bowel is affected by the flow of chyme from the colloideal reflex, and its visceral hypersensitivity can contribute to the sense of urgency and tenesmus of proximal colonic transit. The neurogenic aspects of colon motility are poorly understood and need further study. Some of the stimuli thought to affect colonic activity are awakening from sleep or rest, ingestion of a high-calorie meal, and the sight or smell of food. Next we will discuss diagnostic criteria. The definition of constipation varies widely between healthcare providers and patients. Constipation can be idiopathic and is functionally defined as infrequent bowel movements accompanied by straining. Feces are hard, leading to straining and a feeling of incomplete evacuation of the rectum. An important distinction between chronic constipation and IBS is the absence of abdominal pain associated with the bowel pattern. The diagnosis of constipation stems primarily from the history. A careful history, as shown in box 30.3, can help the provider decide which diagnostic tests may be appropriate. Abrupt onset of constipation or onset in patients ages 45 to 50 suggests an organic cause and requires immediate attention, according to Dosch in 2002, according to Schiller in 2001, and according to Stessman in 2003. Next we will look at initiating drug therapy. Lifestyle modifications are preferred over pharmacologic therapy for treating constipation. Diet, exercise, and bowel habit training are usually targeted. However, research is inconclusive as to the value of increasing fluid intake and exercise, according to Muller-Lissner and colleagues in 2005. According to the National Center for Health Statistics, Americans eat 5 to 14 grams of fiber daily, far short of the recommended 20 to 35 grams recommended by the American Dietetic Association, according to American Dietetic Association in 2002. Dosch, 2002. Increased dietary fiber can be recommended for most patients without fear of colon obstruction. Fiber should be both soluble and insoluble in the form of fruits, vegetables, and whole grains, which cannot be digested by the body. Fiber should be slowly increased to 20 to 25 grams per day over a 1 to 2 week period to improve compliance with therapy. Dietary fiber increases stool weight and shortens intestinal transit time. However, fiber therapy may not be effective for all patients. Fiber accelerates right colon transit, but there are few treatments for patients where the transit problem is the left colon. One additional lifestyle modification includes establishing a regular pattern for bathroom visits. Patients should also be counseled not to ignore the urge to defecate, because this delay increases the time for absorption of fluid from the stool. Biofeedback, a method of retraining the pelvic floor muscles to relax during defecation, may be effective in selected patients. Next we will discuss the goals of drug therapy. An adequate trial of lifestyle modification should be attempted first. If this fails, pharmacologic management with laxatives may be appropriate. There is no evidence that laxatives cause dependency and should be withheld from long-term treatment, according to Medscape in 2005, and according to Wald in 2006, and in 2007. The goal of therapy for constipation is to increase the water content of the feces and increase motility of the intestines to promote comfortable defecation, using the lowest effective dose of a laxative for the least amount of time possible. Only if a patient fails therapy should the healthcare provider consider ordering colon transit studies to evaluate the transit time of stool in the intestine, according to Wald in 2006. Responses to laxatives vary and depend on the patient as well as the preparation. Several classes of laxatives are available for the symptomatic treatment of constipation: bulk-forming agents, saline laxatives, lubricant laxatives, surfactants, emollients, hyperosmotic laxatives, and stimulant laxatives. Proper selection of a laxative should be based on the individual clinical situation, as shown in Table 30.1. Next we will look at bulk-forming laxatives. Bulk-forming laxatives work by binding to the fecal contents and pulling water into the stool. This ultimately softens and lubricates the stool, eases its passage, and reduces straining. Water is reabsorbed from fecal masses that stay in the colon for extended periods, and the result is dry stools. Bulk-forming agents hold water in the stool or swell and increase stool bulk. The bulk stimulates the movement of the intestines and facilitates the passage of intestinal contents. These types of laxatives are not useful when constipation results from the use of opioid medications. Bulk-forming laxatives generally consist of psyllium seed husk, methylcellulose, polycarboxyl, and wheat dextrin, which are made of polysaccharides, cellulose derivatives, or wheat starch such as methylcellulose, marketed as Citracel, or psyllium, marketed as Metamucil. Polycarboxyl, marketed as Fibercon, and wheat dextrin, marketed as Benefiber, have significant water absorptive properties and also are used as antidiarrheals. All bulk-forming agents used for constipation should be taken with plenty of fluid, 8 ounces, to increase efficacy. Malt soup extract, marketed as Maltsupex, made from barley malt, reduces fecal pH. This may contribute to its laxative effect. Traditionally, these products have been marketed only as powders, which must be dissolved in water. Now many fiber products are available in powder, wafer, and caplet forms. Patients may need to try several before finding one that works for them. Brand names include Metamucil, Fibercon, and Citracel. Metamucil is the preferred agent because it is the safest and most physiologic. Sugar-free methylcellulose and psyllium products are available for patients with diabetes. Patients with celiac disease or gluten intolerance should avoid using wheat dextrin products. Contraindications to the use of bulking agents are symptoms of an acute surgical abdomen, intestinal obstruction or perforation, or inability to drink an adequate amount of fluid. Action for all agents may begin in 12 to 24 hours, but a full effect is not usually seen for up to 3 days. A half cup to 1 bowl daily of wheat bran can provide adequate fiber supplementation, but synthetic forms of fiber are often better absorbed than food. Other foods can also add fiber to the diet and should be reviewed with the patient. The patient should be encouraged to drink adequate amounts of fluid throughout the day. If not contraindicated, up to 2,500 milliliters is preferred. These agents are more likely to be used as preventive measures. However, given, they can take effect within 12 to 24 hours, and some acute relief of symptoms is possible. Next we will focus on adverse events. Overall, these agents are usually well tolerated, but compliance can be a problem because the most common side effect is increased flatulence, and some bloating can occur. With severe constipation, all agents can cause abdominal fullness and cramping. If these agents are used excessively, nausea and vomiting may occur. Contraindications: because bulk-forming laxatives have the most physiologic effect and are not systemically absorbed, they are the preferred agents for symptomatic treatment of constipation. However, these agents are not completely benign and should be avoided in patients with strictures of the esophagus, gastrointestinal ulcerations, or stenosis secondary to the possibility of obstruction from increased bulk of intestinal contents. In addition, some bulk-forming agents may contain as much as 20 grams of carbohydrates per dose. Sugar-free bulk-forming agents are available and are recommended for diabetic patients. Interactions: the sugar-free preparations may contain aspartame, which is metabolized to phenylalanine and should be used cautiously with patients who must restrict their phenylalanine intake. Wheat gluten is a byproduct of extracting the gluten from wheat. However, complete extraction cannot be guaranteed and should be avoided in patients with gluten intolerance. Concomitant administration of calcium-containing bulk laxatives may reduce the effectiveness of quinolone or tetracycline, so patients should separate the administration time of these agents. And now we will look at hyperosmotic laxatives. Lactulose, marketed as Cephilac, sorbitol, polyethylene glycol, electrolyte solution, marketed as PEG-ES, or Colite, and polyethylene glycol, marketed as PEG, or Mira-Lax, are examples of hyperosmotic laxatives. These agents serve as are metabolized to solutes in the intestinal tract. The increased concentration of solutes creates osmotic pressure by drawing fluid from a less concentrated gradient to the more concentrated gradient inside the gastrointestinal tract. This increase in osmotic pressure stimulates intestinal motility and propulsion of fecal contents. The PEG products do not degrade colonic bacteria and therefore produce less bloating. Glycerin, marketed as Collis suppository, Fleet glycerin suppository, Pedia-Lax suppository, helps the stool to evacuate by similar mechanisms, but also provides local rectal stimulation. In addition to its osmotic effect, glycerin also has a local irritant effect in the suppository form. The irritant action adds to the osmotic action to stimulate bowel movement. Lactulose is a disaccharide analog that is metabolized by bacteria to acids that increase osmotic pressure and acidify the contents of the colon. The result is increased intestinal motility and secretion. In addition to its use for the symptomatic treatment of constipation, sorbitol is also used to prevent constipation in combination with activated charcoal for poisoning. Sodium polystyrene sulfonate, marketed as Kxalate, a cation exchange resin used for treating hyperkalemia, is often combined with sorbitol to reduce the potential for constipation from the resin. PEG-ES is a non-absorbable solution that acts as an osmotic agent. It is usually used to evacuate the bowel before a GI examination such as a flexible sigmoidoscopy or colonoscopy. The solution is reconstituted with 1 gallon of tap water and should be chilled before consumption to increase palatability. The patient should begin drinking the solution at 4 p.m. the day before the procedure. 1 glass, that is 8 ounces, of the reconstituted solution should be consumed every 10 minutes over 3 hours until all 4 liters are consumed. The patient should fast for 4 hours before ingesting the solution, and only clear liquids are allowed after ingestion. Next we will focus on contraindications. Lactulose syrup should be used with caution in diabetic patients because it contains lactose and galactose. Lactose is also contraindicated in patients with appendicitis, acute surgical abdomen, fecal impaction, or intestinal obstruction. Caution must be used in diabetic patients because of sugar content. Other osmotic agents such as magnesium hydroxide, that is milk of magnesia, or magnesium citrate, that is citrama, can be used to promote defecation. Approximately 15% to 30% of the magnesium in these agents may be absorbed systemically. Therefore, caution is needed in patients who have renal failure and decreased ability to excrete magnesium. When taken appropriately, these agents are well tolerated. The most common adverse events are abdominal cramping and nausea. Evidence is lacking that extensive, long-term use of these agents can lead to laxative dependence, according to Brandt and colleagues in 2005. However, the use of these agents may be counterproductive in patients with changes in colonic transit time, irritable bowel syndrome, or severe bloating and fullness, according to Wald in 2006. In addition, sorbitol as a caloric sweetener has the potential to affect blood glucose levels and should be used with caution in diabetic patients. PEG-ES is not recommended in patients with gastric obstruction, bowel perforation, or colitis. Next we will discuss the adverse reactions. Glycerin is among the safest laxative preparations available and is often used in infants and children. Rectal irritation is the most common side effect of glycerin suppositories. The most common side effects associated with lactulose and sorbitol include gastrointestinal upset and diarrhea. PEG-ES rapidly cleanses the bowel and often causes nausea, abdominal fullness, cramps, and bloating. Interactions. There are few documented interactions with the osmotic laxatives. However, because antacids may neutralize the acids produced from lactulose and interfere with its mechanism of action, concomitant administration of antacids should be avoided with lactulose. No other medications should be given within 1 hour of consumption of PEG-ES, because the medication will likely be flushed from the gastrointestinal tract. Next we will progress to the saline laxatives. Like hyperosmotic laxatives, saline laxatives draw water into the intestine through osmosis. This creates an increase in intraluminal pressure and a resultant increase in intestinal motility. Magnesium citrate, citrate of magnesia, magnesium hydroxide, marketed as Phillips milk of magnesia, magnesium sulfate, marketed as Epsom salt, sodium phosphate, and sodium biphosphate, marketed as Fleet phosphor soda, are examples of saline laxatives. Magnesium citrate and sodium phosphate and biphosphate are used as bowel evacuants for endoscopic examinations such as flexible sigmoidoscopy. A typical dose is 1 bottle of magnesium citrate at 4 p.m. the day before the test and 2 Fleet enemas 1 hour before leaving home the morning of the test. And now we will look at contraindications for the use of saline laxatives. Caution should be used when administering sodium phosphate salts to patients on sodium-restricted diets, e.g., hypertension, congestive heart failure, and edema. In addition, phosphates can accumulate in patients with renal dysfunction, leading to serious complications such as hyperphosphatemia, hyperkalemia, hypercalcemia, hypernatremia, metabolic acidosis, and coma. Magnesium hydroxide and magnesium sulfate are commonly used for the symptomatic treatment of constipation. Because the kidneys eliminate magnesium, magnesium-containing laxatives should be used with caution in the elderly and in patients with decreased renal function. Excessive magnesium levels can result in central nervous system depression, i.e. drowsiness, muscle weakness, decreased blood pressure, and electrocardiographic changes. And now we will briefly talk about the adverse events of saline laxatives. Dehydration is a concern with the use of saline laxatives, and these agents must be used with caution in patients who cannot tolerate excessive fluid loss and dehydration. Interactions. Because milk of magnesia also has antacid properties and can increase the pH of the intestines, it should not be administered at the same time with agents that require an acidic environment to be absorbed. The most common example of this type of interaction is with the antifungals itraconazole, marketed as Sporanox, and ketoconazole, marketed as Nazorol. Therefore, administration of any antacid should be separated from administration of ketoconazole or itraconazole by at least 2 hours. In addition, the magnesium found in magnesium hydroxide and magnesium sulfate combined with tetracycline and quinolone antibiotics to form a non-absorbable complex that may reduce the effectiveness of the antibiotics. Administration of quinolones and tetracyclines should be separated from administration of magnesium-containing compounds. Pause the video and carefully scrutinize Table 30.1 summarizing an overview of selected laxatives before proceeding to the next slide. Pause the video and carefully scrutinize Table 30.1 summarizing an overview of selected laxatives before proceeding to the next slide. We will now progress to the stimulant laxatives. These laxatives vary in effects, but act by increasing peristalsis through direct effects on the smooth muscle of the intestines and simultaneously promoting fluid accumulation in the colon and small intestine. Because of the irritating effect of the agents on the musculature, these agents should be avoided in long-term treatment. Stimulant laxatives include Bisacodyl, marketed as Dulcolax, and Senna concentrates, marketed as Senocot, Senocot S. Overall, stimulant laxatives have short-term usefulness and are not superior to bulking agents. There is little evidence that stimulant laxatives create permanent injury to the colonic mucosa, according to Brandt in 2005. And now we will look at contraindications to the use of stimulant laxatives. As with other laxatives, stimulants are contraindicated in patients with appendicitis, acute surgical abdomen, fecal impaction, or intestinal obstruction. Rectal fissures and hemorrhoids can be exacerbated by stimulation of defecation. Action begins 6 to 10 hours after oral administration and 15 minutes to 2 hours after rectal administration. We will now look at the adverse events of stimulant laxatives. These agents are not as well tolerated as the osmotic laxatives or bulking agents because of their side effects, which include nausea, vomiting, and abdominal cramping. These side effects can be more severe with cases of severe constipation. Long-term or excessive use can lead to laxative dependence. And now we will focus on surfactant laxatives. This class of laxatives reduces the surface tension of the liquid contents of the bowel. Ultimately, this promotes incorporation of additional liquid into the stool, forming a softer mass, and promotes easier defecation. However, stool softeners have insufficient data to support their efficacy, and fiber products may be superior to improved stool frequency, according to Brandt in 2005. Examples of this class include docusate sodium, marketed as Colus, and docusate calcium, marketed as Surfac. For patients who should not strain during defecation, this is the laxative of choice. Emollient laxatives only prevent constipation. They do not treat it. Combining these agents with fiber products helps promote defecation. Administration of emollient laxatives concomitantly with mineral oil is contraindicated because of increased absorption of the mineral oil. Action with these agents usually occurs between 1 and 3 days. Let's now consider contraindications to the use of surfactant laxatives. Docusate calcium or docusate potassium may be recommended for patients on sodium-restricted diets, e.g., hypertension, and congestive heart failure. The sodium content of Colus, marketed as docusate sodium, is quite small, that is 5.2 mg per capsule, and is likely insignificant. Next we will discuss the adverse events of surfactant laxatives. These agents are extremely well tolerated when used to prevent constipation. The most common side effect is stomach upset. Other side effects, such as mild abdominal cramping, diarrhea, and throat irritation, are infrequent. Patients should take surfactants with plenty of water to improve effectiveness. Interactions docusate, as a surfactant emollient laxative, may increase the absorption of mineral oil and potentially increase the risk for liver toxicity. Therefore, this combination should be avoided. And now we will focus on the lubricant laxatives. Mineral oil coats and softens the stool and prevents reabsorption of water from the stool by the colon. Lubricant laxatives are effective at preventing straining in high-risk patients, e.g., rectal surgery, labor and delivery, stroke, hemorrhoids, hernia, myocardial infarction. Contraindications to the use of lubricant laxatives. Mineral oil may be aspirated and cause lipid pneumonia when administered to young, elderly, or bedridden patients. With the availability of safer laxative preparations, mineral oil should probably be avoided in these populations. If mineral oil is chosen, it should not be administered to patients before bedtime or when they are reclining to prevent aspiration. We will now discuss the adverse events of lubricant laxatives. Mineral oil has an unpleasant taste, and because it is not absorbed, large single doses can seep through the anal sphincter and cause irritation. Dividing doses may prevent this. Let's now focus on the interactions of lubricant laxatives. Mineral oil can impair the absorption of fat-soluble vitamins A, D, E, and K because warfarin, marketed as Coumadin, interferes with the synthesis of vitamin K-dependent clotting factors. A reduction in absorption of vitamin K may increase the effects of the anticoagulant. Although no direct interactions with oral anticoagulants have been reported, prothrombin levels may decrease. The docusates, as surfactant emollient laxatives, may increase the absorption of mineral oil and potentially increase the risk for liver toxicity. Therefore, this combination should be avoided. Next we will discuss chloride channel activators. Initially approved for chronic constipation in 2006, currently this class has only one drug, lubiprostone, marketed as Amitiza, and is derived from prostaglandin. While the entire mechanism is not understood, it appears to work by enhancing chloride-rich intestinal fluid without altering serum sodium and potassium concentrations. The activation of the chloride channel in the intestines pulls water into the lumen of the intestine. The drug is poorly absorbed systemically and appears to act locally on the intestines, improving stool consistency and motility. Lubiprostone is approved for treatment of adults with chronic constipation. Contraindications to the use of chloride channel activators. Lubiprostone is contraindicated in patients with potential mechanical obstruction, severe diarrhea, or hypersensitivity to components of the product. It is contraindicated in pregnant women and children. We will now focus on the adverse events of chloride channel activators. Nausea is the most common side effect of lubiprostone. The rate of nausea is dose-dependent and was experienced by approximately 29% of patients. Other common gastrointestinal side effects include diarrhea, abdominal pain, abdominal distension, and flatulence. The most commonly reported neurologic side effect is headache. And now let's talk about the interactions of chloride channel activators. No drug-drug interactions have been discovered with lubiprostone. In vitro studies showed the cytochrome P450 isoenzymes are not inhibited by the drug. We will now look at selecting the most appropriate agent. If lifestyle modification fails to reverse constipation, then selection of an appropriate laxative is necessary. The choice of laxative agent depends on several factors, including medical history, goal of therapy, concomitant medications, the potential for side effects, age, and personal preference. Table 30.2 describes first, second, and third-line therapies, as shown in Figure 31. Let's begin with first-line therapy. Provided no contraindications exist, a bulk-forming laxative is usually chosen as first-line therapy for constipation. Bulk-forming laxatives are not systemically absorbed. In addition, their pharmacologic effect is the most physiologic, meaning they have an effect similar to that of the natural effect of fiber from food on the gastrointestinal tract. Their side effects are usually mild, and if necessary they can be administered safely for longer durations than other classes of laxatives such as the stimulants. When hard or dry stools are the chief complaint or in situations where straining should be avoided, e.g., hernia, cardiovascular disease, a stool softener such as Docusate is considered first-line therapy. Stool softeners also are not systemically absorbed and their side effects are usually minimal. Glycerin suppositories have a local irritant effect on the rectum and are probably the safest of all preparations. This is preferred as first-line therapy in infants. Next we will discuss second-line therapy. If a more rapid onset of action is desired, magnesium hydroxide may be chosen. Although it has a faster onset of action, dehydration from excessive use is a concern, particularly in patients unable to tolerate excessive fluid loss. In addition, magnesium-containing preparations should be avoided in patients with renal insufficiency or the elderly. If the bulk-forming agents and magnesium hydroxide are ineffective or contraindicated, an osmotic laxative such as lactulose or sorbitol may be chosen. However, flatulence and the sweet taste limit compliance. In addition, lactulose and sorbitol should be used with caution in patients with diabetes mellitus. Next we will discuss third-line therapy. If bulk-forming or osmotic diuretics fail to work, a stimulant laxative may be chosen. Stimulant laxatives are very effective but have the highest potential for abuse. This high potential for abuse can cause serious complications. Therefore, stimulant laxatives should be reserved as third-line agents after other agents have failed or are contraindicated. Mineral oil is effective as a lubricant laxative and may be an option in patients who should avoid straining. However, although mineral oil would seem safe, its ability to impair absorption of necessary vitamins and to cause aspiration pneumonitis limits its use. In addition, seepage is an inconvenient side effect that likely limits compliance. If an agent is necessary to soften the stool to prevent straining, docusate is a safer alternative. Sodium biphosphate as an oral solution or enema is another option. These agents have the potential to cause fluid and electrolyte abnormalities and exacerbate concomitant disease states such as hypertension and congestive heart failure. Therefore, these agents should be used only after safer agents have failed. Because sodium biphosphate enemas and magnesium citrate solutions have a rapid onset of action, these agents are often preferred and are usually reserved for endoscopic procedures. Castor oil is a potent cathartic that should not be used routinely for treating constipation. Let's now shift gears to special populations. Let's begin with the pediatric population. Constipation can be distressing for children, particularly young children. Most children do not have an underlying pathophysiologic process. Stress over potty training or painful stools secondary to acute constipation can result in avoidance of defecation by the child. This in turn can result in larger, harder, and more painful stools, which eventually leads to soiling. Constipation and encopresis, a condition where soft stool is involuntarily lost, are often combined. Parents usually pay little attention to their child's bowel frequency unless incontinence occurs. The parents may become angry with the child, leading to further stress. To avoid constipation that may result in soiling, parents should be cognizant of their child's bowel habits. Constipation may also result in urinary incontinence and urinary tract infections in children, particularly girls. Overflow incontinence may occur when the distended rectum presses on the bladder wall, causing bladder outflow obstruction. Fecal soiling in the external urethral opening predisposes constipated girls to infection. Treatment of constipation can reduce infection and incontinence. Initially, manual evacuation of the rectum may be necessary. However, once this is done, it is necessary to use chronic laxative therapy, according to Borowitz in 2005. Treatment with pharmacologic agents in children is controversial, and few well-designed placebo-controlled trials have been conducted on the use of osmotic laxatives, fiber, formula switching, sorbitol-containing juices, rectal stimulation by thermometer, or glycerin suppositories. The use of sodium phosphate enemas in children under 2 years of age has been associated with electrolyte disturbances, dehydration, and cardiac arrest. For infants, malt soup extract or corn syrup, marketed as Caro, may be used at a dosage of 5 to 10 milliliters twice daily. For children older than 6 months, milk of magnesia, lactulose, or sorbitol at a dosage of 1 to 3 milliliters per kilogram per day given in 1 to 2 doses may be used. Senna syrup at a dosage of 5 to 10 milliliters per day for children ages 1 to 5 and 10 to 20 milliliters per day for children ages 5 to 15 is another option. Next we will discuss the geriatric population. The choice of a laxative preparation may depend on the patient's attitude or beliefs about normal bowel habits. Normal bowel frequency can range from 2 or 3 bowel movements per day to 2 or 3 per week. However, many people think that less than 1 bowel movement per day is abnormal. These patients may seek an over-the-counter laxative to keep them regular. This concern about regular bowel movements is particularly common in the elderly. The self-reported incidence of constipation increases with advancing age, but the actual bowel movement frequency usually does not decline. The overuse of laxatives in the elderly can be of particular concern because this population is more intolerant to the fluid and electrolyte abnormalities that accompany laxative abuse. In addition, many of the laxatives should be used with caution in elderly persons because they are more likely to have the disease states that some laxatives can exacerbate, e.g., heart failure, hypertension. Elderly patients are also more likely to take medications that may cause constipation, such as antipsychotics, tricyclic antidepressants, calcium supplements, and certain blood pressure medications. Elderly patients should be carefully assessed to determine the cause of the constipation, and causative factors should be eliminated. Careful selection and judicious use of laxatives are necessary to avoid complications in this population. Next we will discuss the women. Girls and women with bulimia or anorexia nervosa may abuse laxatives as a means of reducing nutrient absorption to cause weight loss. Bulimia is 10 times more common in women than in men. It affects up to 3% of young women. For the pregnant woman, the use of laxatives that are not absorbed into the systemic circulation, such as docusate and bulk-forming agents, should be considered as first-line therapy. Docusate sodium has not been found to be associated with fetal malformations and may be safe to use during pregnancy. Lactulose and sorbitol have not been found to be teratogenic in animals and may be safe to administer to pregnant women. Stimulant laxatives should be used only occasionally, if necessary. Cascara sagrada may cause loose stools in breastfed infants. Castor oil should be avoided in pregnant women because of the risk of stimulation of uterine contractions. Mineral oil should be avoided because its use can reduce the absorption of necessary vitamins by the mother, which may result in deficiencies for the neonate. Pause the video and carefully scrutinize Table 30.2 summarizing the recommended order of treatment for constipation before proceeding to the next slide. Pause the video and carefully scrutinize Figure 31, which is a treatment algorithm for constipation before proceeding to the next slide. We will now discuss monitoring patient response. Monitoring the patient's response to laxative therapy usually is accomplished by asking the patient whether he or she has regained normal bowel patterns after using the laxative. Different patients have different perceptions of what normal bowel habits are. Patients should be informed that the reason for treating with a laxative is not to increase the frequency of defecation, but to promote comfortable defecation. Any misunderstanding by the patient on the goal of therapy may lead to chronic abuse of laxatives. Next we will look at patient education. In most cases, the occasional use of laxatives poses no major problems for the patient. Laxatives are relatively safe when used in moderation. However, the fact that many laxatives are available over the counter may give consumers the false impression that these agents are not dangerous and can be used routinely. Healthcare providers should warn patients of the potential complications of laxatives. Over-the-counter laxatives carry a warning for the consumer not to use them for more than 7 days. For chronic constipation, use of a bulk-forming laxative may be a safer alternative, provided no contraindications exist. However, patients should be counseled that bulk-forming laxatives take time to work, up to 3 days. Because patients are usually looking for an immediate response, they may draw the conclusion that these agents are not effective if a bowel movement has not occurred within the first day. The next step taken by the patient is usually to look for a more potent agent such as a stimulant laxative, which may lead to chronic use and abuse. We will now talk about patient-oriented information sources. Providing patients with information about constipation can help them understand constipation and their role in treatment. Patient education items are readily available on the Internet through the National Digestive Diseases Information Clearinghouse, which provides information to consumers on a wide variety of gastrointestinal topics. Next, we will consider nutrition or lifestyle changes. Patients should be educated on the lifestyle modifications discussed previously to reduce the need for a laxative. An increase in fluid intake improves the efficacy of most laxatives. Patients should also be educated on the potential for side effects of the laxative chosen as well as the appropriate method to administer the laxative. And now let's progress to complementary and alternative medications. Little evidence exists that any specific herbal supplement or alternative treatment works to relieve constipation, according to Brandt and colleagues in 2005. However, senna is used as a laxative, acting similar to cascara, which was withdrawn from the market. It increases peristaltic activity in the lower bowel, has anti-absorptive properties, and stimulates secretions. Next, we will discuss diarrhea. True diarrhea is an increase in frequency of loose, watery stools, 3 or more daily, usually over a period of 24 to 48 hours. It is a relatively common disorder of the gastrointestinal tract that is experienced occasionally by most people. The organisms that cause diarrhea are easily transferred from person to person through food and water. Globalization and industrialization of the world has increased the ability of these organisms to spread. The Centers for Disease Control and Prevention, CDC, estimates that 211 million people experience acute diarrhea every year. An average of 16 million seek medical attention, resulting in 1.2 million hospitalizations and 600 deaths, according to Bushen and Geraint in 2003. Children, the elderly, and those who are immunocompromised are most susceptible to the complications of diarrhea, and serious dehydration can result from the disorder. Proper hydration and symptomatic treatment as well as elimination of causative factors are necessary to prevent these complications. Ultimately, diarrhea can have a profound impact on public health, and proper diagnosis and treatment can prevent an epidemic. We will now look at the causes of diarrhea. Diarrhea may be caused by a host of different medications, as shown in box 30.4, infective organisms, as shown in box 30.5, or disease states or procedures, as shown in box 30.6. Prompt attention to causative factors, as well as rehydration, prevents complications. Medications. Antibiotics may cause diarrhea by direct irritation of the intestinal tract, or disruption of the normal intestinal flora. The poor absorption of erythromycin, marketed as E-mycin, lends itself to irritation of the gastrointestinal tract. Clarithromycin, marketed as Biaxin, and azithromycin, marketed as Zithromax, may cause less diarrhea than erythromycin. The clavulanic acid component of the combination of amoxicillin-clavulanic acid, marketed as Augmentin, is also a gastrointestinal irritant, and diarrhea is a common side effect. Tetracycline and ceftriaxone, marketed as Rocephin, cause diarrhea by disrupting the normal balance of the gut flora. Clostridioides difficile, a normal part of the flora of the colon in up to 20% of hospitalized patients, normally does not cause disease unless chemotherapeutic medications or antibiotics trigger its toxins. Only certain antibiotics have been implicated in Clostridioides difficile-associated diarrhea. Less common causes of Clostridioides difficile diarrhea are vancomycin, vancomycin, erythromycin, tetracyclines, trimethoprim sulfamethoxazole, abbreviated as TMPSMZ, quinolones, and aztreonam, marketed as Azactam. The antibiotics most likely to cause Clostridioides difficile diarrhea are beta-lactam antibiotics, e.g. penicillins, cephalosporins, carbapenems, and clindamycin, marketed as Cleocin. Box 30.7 gives more information. Pause the video and carefully scrutinize box 30.4 summarizing the medications commonly causing diarrhea before proceeding to the next slide. Pause the video and carefully scrutinize box 30.5 summarizing the infective organisms associated with diarrhea before proceeding to the next slide. Pause the video and carefully scrutinize box 30.6 summarizing the disorders and procedures associated with diarrhea before proceeding to the next slide. Pause the video and carefully scrutinize box 30.7 summarizing treating Clostridioides difficile diarrhea before proceeding to the next slide. Let's now focus on infectious organisms. Patients traveling to a developing region may contract diarrhea from bacterial organisms. Giardia should be suspected if the patient travels to mountainous areas, recreational waters, or Russia. Pathogens transmitted by the fecal to oral route should be suspected in homosexual men, e.g. Shigella, Salmonella, Campylobacter, and intestinal protozoa, and in patients exposed to daycare centers, e.g. Shigella, Giardia, or Cryptosporidium. Travelers' diarrhea is usually a self-limiting, non-life-threatening illness. It affects 20% to 50% of people visiting developing countries. The cause is ingestion of fecally contaminated food products or water. High-risk areas include Latin America, Africa, Asia, and the Middle East. The typical duration is 2 to 3 days. Symptoms include nausea and vomiting, cramps, and bloody stools. The most common pathogen is Escherichia coli. Salmonella, Shigella, and Campylobacter are the culprits less frequently. Dietary restrictions are the main prevention for travelers' diarrhea. Travelers should avoid foods and beverages that are not steaming hot, raw vegetables, unpeeled fruit, tap water, and ice. Next we will discuss the pathophysiology of diarrhea. Diarrhea may be classified by duration and category. Acute diarrhea lasts 1 to 14 days and is considered self-limiting. Persistent diarrhea lasts longer than 14 days, but less than 30 days, and chronic diarrhea lasts more than 30 days. Diarrhea may also be categorized as osmotic, secretory, or exudative, that is inflammatory, or the diarrhea may be related to altered intestinal motility, that is transit. Some diarrheal illnesses involve more than one of these mechanisms. Diarrhea may also be a defense mechanism against toxins and invading organisms. Next we will discuss osmotic diarrhea. Osmotic diarrhea occurs when non-absorbed solutes are retained in the lumen of the intestinal tract. The result is a hyperosmolar state that pulls water and ions into the intestinal lumen. Poorly absorbed salts, e.g. magnesium sulfate, lactose, in lactase deficiency, and large amounts of sugar substitutes, e.g. sorbitol, found in candy or chewing gum, diet foods, and soft drinks draw fluid into the intestinal tract, resulting in an overload of the colon. Next we will look at secretory diarrhea. In secretory diarrhea, colonic absorption of fluid is secondary to active transport of sodium ions through sodium-potassium adenosine triphosphatase activity in the colonic epithelium. The colon absorbs chloride by exchanging it for bicarbonate and by uptake of sodium chloride. Any agent that increases concentrations of cyclic adenosine 3,5-monophosphate in the cells of the colon inhibits sodium chloride uptake and causes secretion of chloride. This results in secretion of fluid in the colon. Prostaglandins E2 and I2 and vasoactive intestinal peptides stimulate adenyl cyclase activity. Cholinergic agents and cholinesterase inhibitors cause secretion of sodium chloride and water. Secretory diarrhea can be classified as pure, e.g., cholera, or a part of a complex disease process, e.g., celiac disease, or Crohn's disease. Other stimuli that can cause secretory diarrhea include bacterial endotoxins, hormones from endocrine neoplasms, dihydroxy bile acids, hydroxylated fatty acids, and inflammatory mediators. Certain laxatives, senna, or castor oil, and bile acids may also induce secretory diarrhea. Next we will look at exudative diarrhea. Exudative, that is inflammatory, diarrhea may result from inflammatory diseases of the mucosa. Inflammation occurs due to the compromise of the tight junctions of the epithelial cells in the intestine. These diseases may cause an increase of blood, mucus, pus, and serum proteins that increase fluid and overload the colon, resulting in diarrhea. Enteritis, ulcerative colitis, and carcinoma are examples of inflammatory conditions that may result in exudative diarrhea. Let's now consider altered intestinal motility. Intestinal contents need to have sufficient time to be in contact with the lining of the intestinal tract for fluid, electrolytes, and nutrients to be absorbed adequately. Any factor that increases or decreases the motility of the intestinal tract may result in decreased absorption of fluid and electrolytes. Resection of the bowels, vagotomy, and certain agents, e.g. serotonin, laxatives, prostaglandins, and prokinetic agents, can increase intestinal motility. Decreases in motility can result from autonomic injury or smooth muscle injury to the intestine and result in bacterial overgrowth, subsequently leading to diarrhea. Let's now look at the diagnostic criteria. A careful travel and social history is important to identify and treat specific causes, such as infection. Use of empiric antibiotic therapy is not recommended due to increasing resistance of many strains of bacteria. Selective testing of stool will be cost-effective while helping to guide the clinician in the use of specific therapy. According to the guidelines of the Infectious Disease Society of America, according to Geraint and colleagues in 2001, diarrhea can be divided into 3 categories: community-acquired or traveler's diarrhea, nosocomial diarrhea, or persistent diarrhea. Each category can be specifically evaluated, leading to more precise therapy. The fecal leukocyte, lactoferrin, or hemoccult blood test is useful in patients with moderate to severe cases of acute infectious diarrhea, because it supports the use of empiric antibiotic therapy in the febrile patient. However, measuring fecal leukocytes can be unreliable if specimens are transported, refrigerated, or frozen. Fecal lactoferrin, as a measure of polymorphonuclear neutrophils, has an advantage over fecal leukocytes as a highly sensitive and specific testing method for intestinal inflammation. Stool cultures have traditionally been used to identify the pathology of diarrhea, but the positive yields are very poor and incur high costs. Controversy exists regarding when to obtain stool cultures. The absence of vomiting with persistent diarrhea may also indicate the need for stool cultures. Hypotension, tachycardia, orthostasis, bloody stool, and abdominal pain and tenderness were not found to be good predictors of a positive stool culture. Laboratory evaluation for ova and parasites should be performed in the following. 1. A person not previously treated with empiric antiparasitic therapy. 2. A person with persistent diarrhea for more than 7 days. 3. A person who recently traveled to mountainous regions, Russia, or Nepal. 4. A person who was exposed to infants at daycare centers, or who was exposed through a community waterborne outbreak. 5. A person with bloody diarrhea with few or no fecal leukocytes. And 6. Homosexual men or patients with acquired immunodeficiency syndrome, AIDS, for food or waterborne pathogens. The incubation period and clinical features can give clues as to the source of infection. Diarrhea and vomiting 6 hours after exposure to a food item suggests exposure to Staphylococcus aureus or Bacillus cereus. An incubation period of 8 to 14 hours suggests Clostridium perfringens. With an incubation period greater than 14 hours, with vomiting as the predominant feature, viral agents are suspected. In patients with fever greater than 101.3 degrees Fahrenheit, that is 38.5 degrees Celsius, plus leukocyte, lactoferrin, or hemoccult-positive stools, or acute dysentery, manifesting with grossly bloody stools. The most common pathogens identified by normal stool culture are Shigella, Salmonella, Campylobacter, Aeromonas, and Yersinia. Additionally, patients with grossly bloody stools should be tested for Escherichia coli 157 or HUS. Let's now discuss initiating drug therapy. Most cases of diarrhea are self-limiting and can be self-treated. However, patients with profuse, watery diarrhea with dehydration, passage of blood and mucus, and fever exceeding 101.3 degrees Fahrenheit should be evaluated for an inflammation-producing pathogen. These patients may benefit from antimicrobial therapy. In addition, a good history helps to determine the cause of illness. In diarrhea caused by infectious organisms, the pathogen should be identified so that therapy may be initiated to eradicate the organism and to prevent exposure to unnecessary antibiotics. For traveler's diarrhea, prophylactic agents may be given to patients who should not, cannot, or will not comply with dietary restrictions. Chemoprophylaxis of traveler's diarrhea is controversial and usually is not recommended for patients unless the patient has an underlying illness, AIDS, prior gastric surgery. The purpose of the trip is particularly important, politicians, honeymoon, or the patient cannot or will not comply with dietary restrictions. In such cases, the use of bismuth subsalicylate, marketed as BSS or Pepto-Bismol, 2 tablets with meals and at bedtime, is recommended unless the reason for prophylaxis is a serious underlying illness. In these cases, a quinolone antibiotic should be used. If prophylactic therapy is not prescribed, empiric therapy with a quinolone antibiotic at the first symptoms of diarrhea is recommended, as shown in Table 30.3. Patients should be properly hydrated, and bismuth subsalicylate may be used to treat symptoms. Loperamide, marketed as Imodium, is a more effective option than bismuth subsalicylate, but loperamide should be used with caution in the presence of fever or bloody stools, because the antimotility effects of the drug may prolong disease by reducing the elimination of possible infectious pathogens. If an antidiarrheal medication is necessary, selection should be based on patient-specific variables, including potential side effects, convenience, efficacy, and the patient's symptoms. For patients with moderate or severe traveler's diarrhea, empiric antimicrobial therapy with a quinolone antibiotic may be given. See Table 30.3. Patients with persistent diarrhea lasting 2 to 4 weeks without systemic symptoms or dysentery may be studied for the cause and treated, or given metronidazole, marketed as Flagyl, for empiric anti-Giardia therapy. Pause the video and carefully scrutinize Table 30.3 summarizing indications for empiric and specific antimicrobial therapy in infectious diarrhea before proceeding to the next slide. Pause the video and carefully scrutinize Table 30.4 summarizing an overview of selected antidiarrheals before proceeding to the next slide. Pause the video and carefully scrutinize Table 30.5 summarizing the recommended order of treatment for diarrhea before proceeding to the next slide. And now we will discuss the goals of drug therapy. The goals of drug therapy are to reduce the symptoms of diarrhea and to make the patient as comfortable as possible. Causative factors should be identified and eradicated. Fluid and electrolyte replacement is particularly important to avoid serious complications from dehydration. Rehydration is discussed later in this chapter. Let's now focus on antidiarrheal agents. Several types of drugs are used for the symptomatic relief of diarrhea. They include antimotility agents, adsorbents and absorbents, and the atypical antisecretory agent bismuth subsalicylate. Table 30.4 provides an overview of these drugs, and Table 30.5 covers the recommended order of prescription. Next we will discuss antimotility agents. The antimotility agent loperamide is a congener of the narcotic analgesic meperidine, marketed as Demerol. It is not well absorbed and does not provide analgesic or euphoric effects. Loperamide slows gastrointestinal motility by direct effects on circular and longitudinal muscles in the intestines. Another meperidine congener, diphenoxylate with atropine, marketed as Lomotil, is a controlled substance, Class 5. Let's now discuss contraindications to the use of antimotility agents. The antimotility effects may exacerbate infectious diarrhea by preventing the excretion of the infecting organism, allowing the organism more contact time in the intestines. Caution should be observed in using loperamide in patients with fever, bloody stools, or fecal leukocytes. In non-dysenteric forms of diarrhea caused by invasive pathogens, loperamide can be used, provided antimicrobial therapy is administered. Because loperamide undergoes extensive first-pass metabolism, caution should be used in patients with hepatic dysfunction because excessive side effects, central nervous system toxicity, may occur in these patients. Because of the antimotility effects of diphenoxylate, it should be used with caution in patients with infectious diarrhea associated with fever or bloody stools. Diphenoxylate provides euphoric and analgesic effects at high doses but not at therapeutic doses. For this reason, diphenoxylate is combined with atropine to discourage abuse. Diphenoxylate should be used with caution in patients with liver impairment because the liver extensively metabolizes it. Next we will discuss the adverse events of antimotility agents. Adverse effects of loperamide include abdominal discomfort, constipation, and dry mouth. Although loperamide does not cross the blood-brain barrier, it may still induce drowsiness in some patients. Patients should be warned of the potential for drowsiness before driving or performing activities that require alertness. Although loperamide is usually well tolerated, it is not recommended in children younger than age 4 because shock, enterocolitis, fatal intestinal obstruction, and central nervous system toxicity have occurred. Atropine has anticholinergic effects such as dry mouth, dry eyes, urinary retention, constipation, blurred vision, and tachycardia. Diphenoxylate may cause drowsiness or dizziness, and patients should be warned of these effects and should avoid activities that require alertness. The liquid formulation is recommended in children because the dose needs to be carefully tailored to the child based on age and weight. Diphenoxylate with atropine can cause respiratory depression in infants and young children and should be avoided in children younger than age 4. And now we will shift gears to the interactions of antimotility agents. Diphenoxylate may potentiate the action of depressants such as alcohol, barbiturates, or benzodiazepines. In addition, atropine may potentiate the effects of other agents with anticholinergic properties such as tricyclic antidepressants, antipsychotics, and antihistamines. Diphenoxylate has a structure similar to that of meperidine, and when used concomitantly with monoamine oxidase inhibitors, it can induce a hypertensive crisis. Next we will discuss atypical antidiarrheals. Bismuth subsalicylate has antisecretory, antimicrobial, and adsorbent properties, making it a reasonably useful agent for travelers' diarrhea. Contraindications for the use of atypical antidiarrheals. Bismuth subsalicylate is broken down in the intestinal tract to salicylate. Therefore, it should be used with caution in patients taking aspirin therapy or those hypersensitive to aspirin. In addition, caution should be used in children and adolescents with the flu or chickenpox, because this population is at risk for aspirin-induced Reye syndrome. And now we will discuss adverse effects of atypical antidiarrheals. Side effects of bismuth subsalicylate include black stools, darkening of the tongue, and tinnitus, which can be a potential sign of salicylate toxicity. Let's now look at the interactions of atypical antidiarrheals. Because bismuth subsalicylate has a salicylate component, it may interact with other medications that interact with aspirin, e.g., warfarin. Next we will discuss adsorbents and absorbents. Let's begin with the mechanism of action. Kaolin, pectin, and attapulgite, marketed as Donegal, or cowpectate, are all examples of adsorbents used alone or in combination in antidiarrheal preparations. These agents adsorb water and help to solidify loose stools. Adsorbents are usually given after each bowel movement until diarrhea is relieved or a maximum dose is reached. Dosages of different products and product combinations vary, but the dose of most adsorbents usually ranges from 30 to 120 milliliters or 2 tablets after each bowel movement up to 6 or 7 doses per day for adults. Polycarbofol, marketed as Fibercon, or Fibril, an absorbent, absorbs water in the gastrointestinal tract and is used as an antidiarrheal. Its fiber content also makes it useful as a bulk-forming laxative when taken with plenty of water. Next we will look at the adverse events of adsorbents and absorbents. The most common side effects of the adsorbents are constipation and a feeling of fullness. Absorbents may also produce upset stomach, bloating, and gas. Adsorbents and absorbents are generally considered safe because the medication works locally and is not absorbed systemically. However, adsorbents may not be as effective as antimotility agents at reducing the symptoms of diarrhea. And now let's discuss the interactions adsorbents and absorbents. Adsorbents are not selective and may adsorb nutrients and medications. This interaction must be taken into consideration because several doses may be necessary each day. Separating administration times of adsorbents and other medications is advised. Polycarbofol contains calcium and may interact with fluoroquinolone and tetracycline antibiotics. Next we will discuss selecting the most appropriate agent. The choice of antidiarrheal agent should be based on several factors, including the patient's history, potential side effects of the medication, potential for drug interactions, and efficacy of the available agents, Table 30.5, Figure 30-2. Let's now discuss first-line therapy. Although the adsorbents are not absorbed into the systemic circulation, and are usually safe and well tolerated, they are not as effective at controlling diarrhea as loperamide. Therefore, loperamide may be considered as first-line therapy secondary to its efficacy. Loperamide is also reasonably well tolerated and has few drug interactions. However, patients should be warned about the potential for loperamide to cause drowsiness, particularly patients who must stay alert. Because loperamide is an antimotility agent, it should be used with caution in patients with fever or bloody stools to avoid exacerbation of infectious diarrhea. In addition, caution should be used in patients with liver failure. Pause the video and carefully scrutinize Figure 32, which is a treatment algorithm for diarrhea, before proceeding to the next slide. Next we will discuss second-line therapy. For patients who cannot tolerate loperamide or for those with contraindications, an adsorbent or anti-secretory agent may be chosen. Anti-secretory agents such as bismuth subsalicylate should be used with caution in patients taking warfarin and should be avoided in children or adolescents with the flu. Anti-secretory agents should also be avoided in patients with a documented hypersensitivity to salicylates. Black stools, darkening of the tongue, and tinnitus are side effects that may be disturbing to the patient. Bismuth subsalicylate may be useful for prophylaxis against traveler's diarrhea and may be preferable over the adsorbents in a patient who also has indigestion or stomach upset that accompanies the diarrhea. Although adsorbents may inhibit the absorption of nutrients from the diet and can cause some abdominal cramping, they are usually well tolerated. And now we will focus on third-line therapy. Although diphenoxylate with atropine is an effective agent for treating diarrhea, the atropine component can cause significant anticholinergic effects that may exacerbate certain conditions and interact with other agents with anticholinergic activity. In addition, diphenoxylate is a Drug Enforcement Administration Schedule 5 drug, and its potential for abuse limits this agent to third-line therapy. Let's now look at special populations. Let's begin with the pediatric population. The American Academy of Pediatrics, Provisional Committee on Quality Improvement, Subcommittee on Acute Gastroenteritis, in 1996, published recommendations on the use of antidiarrheals in children. Their recommendations apply to children ages 1 month to 5 years who have no previously diagnosed disorders. They suggested that opiate and atropine combination drugs such as diphenoxylate with atropine be avoided in acute diarrhea in children because of the potential for side effects and the limited scientific evidence for efficacy. The committee also stated that loperamide and bismuth subsalicylate are not recommended based on limited scientific evidence. Adsorbents are also not recommended based on limited evidence. The committee recognized that major toxic effects from adsorbents are in general not a concern, but the potential for poor absorption of nutrients and antibiotics is a potential disadvantage. The committee concluded that oral rehydration is most important and that routine use of antidiarrheal agents is not recommended based on lack of evidence or the potential for side effects. If the healthcare provider still decides to choose diphenoxylate with atropine, the liquid formulation should be used because specific dosing is required based on the child's weight and age. In addition, diphenoxylate with atropine is contraindicated in children younger than age 2. Next we will discuss the geriatric population. As with the pediatric population, rehydration is of paramount importance in the geriatric population. Elderly patients are likely to have multiple disease states that cause them to be intolerant of dehydration, e.g., congestive heart failure, diabetes mellitus, and renal insufficiency. In addition, the antidiarrheal preparations may interact with agents that are commonly prescribed in the geriatric population. Diphenoksalate and loperamide may increase the sedative potential of benzodiazepines, antidepressants, anticholinergics, and antipsychotics. Adsorbents can reduce the absorption not only of important nutrients, but also of other medications. Bismuth subsalicylate should be used with caution in elderly patients taking aspirin and agents that interact with aspirin. Let's now look at the women. As with constipation, antidiarrheals such as the adsorbents that are not absorbed systemically should be considered as first-line therapy for pregnant women with diarrhea. However, adsorbents can inhibit the absorption of important nutrients. Iron supplementation may be particularly important in pregnant women taking adsorbents for diarrhea. Loperamide has not been shown to be teratogenic in animals but has been inadequately studied in humans. Therefore, the routine use of loperamide is not recommended. Diphenoksalate with atropine should be avoided because it has been shown to be teratogenic in animals. In addition, malformations in infants after first trimester exposure have been reported. Both Lomotil and loperamide are excreted in breast milk. Salicylates have been shown to be teratogenic in animals. Therefore, use of bismuth subsalicylate in the pregnant woman should be avoided. Next we will discuss monitoring patient response. For most cases of diarrhea, the major concern is dehydration. Fluid and electrolyte depletion can lead to hypotension, tachycardia, and vascular collapse. Vascular collapse may occur quickly in the very old or the very young. Severe dehydration may result in decreased plasma volume and a decrease in perfusion, which may be of clinical significance, particularly in patients with congestive heart failure or chronic renal disease. Bicarbonate loss from excessive diarrhea may result in metabolic acidosis. This may be of particular concern in patients with type 1 diabetes mellitus who may be prone to ketoacidosis. Patients should be monitored for signs of dehydration, such as orthostatic hypotension and poor skin turgor. The body weight of an infant is mostly water, and therefore infants may be weighed to determine significant fluid loss and dehydration from severe diarrhea. Monitoring serum electrolytes as well as intake of fluid and output of stools benefits patients who are hospitalized secondary to dehydration. As stated earlier, the goal of therapy is not only to prevent dehydration but also to make the patient as comfortable as possible. Monitoring the effectiveness of an antidiarrheal preparation requires interviewing the patient to ensure a decrease in stool frequency and improved formation. Frequency and formation of stools vary from patient to patient, and determination of relief is subjective on the patient's part. Let's now focus on patient education. To avoid complications, patients should be educated about appropriate rehydration. In most cases, simple replacement of fluid and electrolytes with soda crackers, broths, and soups is all that is necessary in the non-dehydrated adult with diarrhea. Oral rehydration solutions should also be considered because most sports drinks do not have enough sodium to replace losses from diarrhea, according to the CDC in 2005. Additionally, food and drink high in sugar content should be avoided because it may increase the osmotic load and worsen the diarrhea. In the elderly or immunocompromised patient, solutions with sodium content in the range of 45 to 75 milliequivalents per liter are recommended. Boiled potatoes, noodles, rice, cereals, crackers, bananas, yogurt, soup, and boiled vegetables are recommended during the acute phase of diarrhea. The diet may return to normal as stools become formed. Infants and children are particularly susceptible to dehydration with diarrhea. Oral replacement therapy is the preferred treatment to replace fluids and electrolytes in children with mild to moderate dehydration, because it is less expensive than intravenous therapy and can be administered in many settings, including the home. Oral glucose electrolyte solutions available in the United States, as shown in Table 30.6, are based on physiologic principles and should be recommended over commonly used non-physiologic solutions such as colas, apple juice, chicken broth, and sports beverages. Currently, oral replacement solutions, abbreviated as ORSs, are recommended for children with mild to moderate diarrhea, according to the CDC in 2003. In addition, age-appropriate feeding should be continued and fluids encouraged. For children with mild to moderate dehydration, 3% to 5% loss of total body weight, 50 to 100 ml per kilogram of ORS is recommended, plus 10 ml per kilogram for each loose stool to replace continuing fluid losses. Severe dehydration, loss of 10% total body weight, can result in shock and is a medical emergency requiring intravenous therapy with normal saline or lactated Ringer's solution. In all situations, age-appropriate feeding should begin after dehydration is corrected. Pause the video and carefully scrutinize Table 30.6 summarizing commercially available oral rehydration solutions before proceeding to the next slide. And now we will take a closer look at drug information. Patients need to be aware of the potential side effects of antidiarrheal medications. Constipation can occur if these agents are taken for too long. Antidiarrheal agents taken in the setting of infectious diseases can prolong or worsen the disease. It is always best to contact a healthcare provider if diarrhea lasts more than 2 days. Let's now shift gears to patient-oriented information sources. Providing patients with information about acute diarrhea and what to expect can help them understand diarrhea and their role in the treatment. Patient education items are readily available on the Internet through the National Digestive Diseases Information Clearinghouse, abbreviated as NDDIC, which provides information to consumers on a wide variety of gastrointestinal topics. The CDC also has a wide array of patient information about diarrhea. And now we will look at nutrition or lifestyle changes. It is not recommended to rest the gut. Oral intake and breastfeeding should continue to replace lost calories during illness. Early feeding will stimulate enterocyte renewal, ultimately promoting a quicker recovery of the gut. Additionally, feeding decreases the potential risk of malnutrition. Let's now focus on complementary and alternative medications. Probiotics have shown some efficacy in the treatment of diarrhea. The presumed mechanism of action is to alter the composition of the intestinal microflora and act against enteric pathogens, according to Guarino in 2009. Yogurt is a source of probiotics. However, not all brands have the active ingredients. Acidophilus capsules can be used to treat diarrhea resulting from antibiotic use. It restores the natural flora to the bowel. 1 to 10 billion viable organisms per day in 3 or 4 divided doses is appropriate. Let's now shift focus to irritable bowel syndrome. Irritable bowel syndrome is a functional bowel disorder that presents with abdominal discomfort and an alteration in bowel pattern. The disorder is an international health problem that can be one of the most perplexing chronic abdominal complaints reported to primary care providers and gastroenterologists. Epidemiologic studies in North America suggest a prevalence of 10% to 15%, with a 4-to-1 female predominance, according to Ringel, al. 2001, while 7% to 10% have irritable bowel syndrome worldwide, according to Brandt and colleagues in 2009. Newer data also suggest that veterans of the Gulf War have a high prevalence of irritable bowel syndrome compared to the general population, which increases the prevalence of irritable bowel syndrome in men, according to Brandt and colleagues in 2009. Once thought to be associated primarily with psychological problems and stress, research is changing to an emphasis on motility of the gut, autonomic system imbalances, and increased visceral hypersensitivity, according to Akbar in 2009. A syndrome in childhood known as recurrent abdominal pain can be a hallmark of adult irritable bowel syndrome. The majority of patients seeking care are ages 20 to 50, and symptoms can wax and wane over a lifetime. We will now discuss the causes of irritable bowel syndrome. For many years, the chief cause of irritable bowel syndrome was thought to be primarily psychological. Now, however, research has identified physiologic but not pathologic causes that are accentuated by psychological stress. Symptoms generally are slow in onset, sometimes over weeks or months, according to Grundmann in 2010. Dysregulation occurs between the brain and the gut, leading to typical irritable bowel syndrome symptoms. Commonly, the symptoms can be worse during times of physical and emotional stress, including sexual or physical abuse. In addition, some patients can identify foods that exacerbate the condition, e.g., lactose, caffeine, and fatty or spicy foods. Depending on the severity of the illness, pharmacotherapy may not be required and symptoms may respond solely to lifestyle changes. These lifestyle changes need to become incorporated into the patient's daily routines. Pharmacologic interventions may be required only intermittently to maintain symptom control. Let's now focus on the pathophysiology of irritable bowel syndrome. In general, the syndrome is believed to have the components of motility and sensory abnormalities. This leads to dysregulation of the bowel as modulated by the central nervous system, CNS. Many neuroimmune and neuroendocrine modulators, such as serotonin, 5-HT, substance P, CCK, neurotensin, cytokines, and others, contribute to the increase in visceral sensitivity, central mechanisms controlling pain and dysregulation of the brain-gut axis. Local reflex mechanisms can also be responsible for mechanical distension of the gut in response to short-chain fatty acids, affecting the emptying rate of the proximal colon. The prevailing theory is that the emptying rate of the proximal colon may be the key determination of overall colon function. The gastrointestinal tract is innervated intrinsically and extrinsically by various neurohormonal agents from local or distant sources. Intrinsic factors include the neurons found in the enteric nervous system, which function similarly to the CNS. Bowel motor dysfunction can be associated with inflammation as well as changes in neurotransmitters, such as 5-hydroxytryptamine, 5-HT3, serotonin. This neurotransmitter is found in the gastrointestinal tract, and blocking it pharmacologically can decrease visceral pain, colonic transit, and gastrointestinal secretions. External factors that can alter colonic activity are eating and drinking, stress, and endogenous hormones. Increased motility and abnormal contractions of the intestinal tract can result in either diarrhea or constipation. Predominant irritable bowel syndrome, due to either accelerated whole gut transit times or delays in colonic transit. The irritable bowel syndrome patient's sensory perception of colonic activity in response to balloon dilatation is more sensitive than that of patients with normal colonic activity. Sensory perception is also accentuated by external factors that lead to enhanced sensations that differ from those of healthy patients. However, evidence is increasing that irritable bowel syndrome is not a psychological illness. This is supported by the fact that irritable bowel syndrome exists in about 12% to 20% of the general adult population. We will now look at the diagnostic criteria of irritable bowel syndrome. The hallmark symptom of irritable bowel syndrome is abdominal pain associated with a change in the consistency of stools that is relieved by defecation. Symptoms are usually first noticed in young adulthood and can be persistent or intermittent. Weight loss, rectal bleeding, fever, acute onset, and onset after age 50 are unusual in irritable bowel syndrome and should raise suspicion of organic causes, not irritable bowel syndrome. Diagnosis can be predominantly based on symptoms and appropriate treatment initiated, with reassessment in 3 to 6 weeks. In 1978, the original Manning criteria proposed identifying irritable bowel syndrome based on the presence of 4 symptoms: abdominal distension, pain relief with bowel action, more frequent stools with the onset of pain, and looser stools with the onset of pain. These criteria led to the establishment of an international group called the Multinational Working Teams for Diagnosis of Functional Gastrointestinal Disorders. This team identified key criteria for irritable bowel syndrome, leading to the establishment of the Rome criteria, as shown in box 30.8. The third revision focused on categorizing each type of irritable bowel syndrome according to constipation, diarrhea, or mixed. However, the overall accuracy of the Rome criteria has led the American College of Gastroenterology, ACG, to simply define irritable bowel syndrome as abdominal pain that occurs with altered bowel habits over a period of 3 months, according to Brandt, et al. 2009. Therefore, for irritable bowel syndrome to be considered as a diagnosis, the presenting clinical features may be sporadic, intermittent, or continuous, but should be present for at least 3 months, as defined by the ACG. The Rome 3 criteria, as shown in box 30.8, can be used to help verify the subtype, which can guide drug therapy. The chief complaint most patients report is abdominal discomfort that can be relieved with defecation. However, symptom relief is often short-lived. Patients can also report abnormal bowel habits that alternate between diarrhea and constipation or are predominantly diarrhea or constipation. It is much more common to have bowel habits that are predominantly one type. Associated components can be abdominal distension, bloating, and gassiness. Extreme urgency after a meal can be common and can possibly result in an explosive bowel movement that relieves the overall discomfort. Organic symptoms of abdominal pain that do not suggest irritable bowel syndrome are those that awaken the patient from sleep, initial onset in the elderly years, a change in abdominal pain that is not associated with bowel movements, significant weight loss, rectal bleeding, steatorrhea, and fever. In addition, steadily worsening symptoms should be considered atypical. These symptoms would suggest the need for additional studies. However, compared to the general population, irritable bowel syndrome patients are not more likely to have organic causes for disease. A key component of irritable bowel syndrome treatment is a thorough history of symptoms, psychosocial stress, medications, because of gastrointestinal symptoms from many drugs, and dietary habits, to identify nutritional patterns, gaps, and intolerances. Even in the general population, stress can result in gastrointestinal symptoms. However, in the patient with irritable bowel syndrome, these symptoms can become more pronounced. The relationship between psychological distress and gastrointestinal symptoms has been well researched. Chronic and acute life stresses, including a history of verbal or sexual abuse, especially in childhood, may preclude early symptoms of irritable bowel syndrome. These chronic stresses can contribute later in life to irritable bowel syndrome symptoms. Physical examination findings are often normal except for a slight diffuse abdominal tenderness with palpation, especially in the left lower quadrant near the sigmoid colon. Mild abdominal distension may also be present. In 2009, the ACG Task Force, in an evidence-based position paper on the management of irritable bowel syndrome in North America, reinforced the recommendation that minimal, if any, testing is necessary. Current treatments were evaluated and the conclusion was reached that care is often based on non-randomized, non-placebo-controlled trials. The best available data show that only 1% of irritable bowel syndrome patients have alarming symptoms signifying serious organic disease. Therefore, for patients without alarming features of irritable bowel syndrome, routine diagnostic studies are not necessary. However, patients who are classified as IBS-D, with diarrhea, or IBS-M, which is mixed, should be routinely tested for celiac sprue disease. Other studies such as abdominal ultrasound, flexible sigmoidoscopy, barium enema, or colonoscopy do not lead to any change in the proposed treatment and are therefore not recommended. Additional testing may be indicated for patients with the key symptoms previously identified or if the patient is older than age 50. Pause the video and carefully scrutinize box 30.8 summarizing the Rome 3 criteria for irritable bowel syndrome, 2006, before proceeding to the next slide. And now we will look at the types of irritable bowel syndrome. According to the Rome 3 criteria, as shown in box 30.8, patient subtypes can be identified according to presentation of diarrhea, constipation, mixed, or unspecified, although this is somewhat controversial. Therefore, along with the subtypes, patients can still be categorized according to mild, intermittent, or continuous IBS according to the predominant features of the patient's stool, according to Longstreth in 2006. Mild irritable bowel syndrome usually shows a sporadic pattern. Symptoms are worsened by stress and dietary factors. There is no alteration in the patient's daily activities because of the symptoms. In intermittent irritable bowel syndrome, the symptoms are worse and begin to affect the patient's daily life. It is more difficult to relate symptoms to specific precipitants, and a psychological component to the syndrome may be developing. In continuous irritable bowel syndrome, the symptoms affect every aspect of the patient's daily routines. An inability to pinpoint precipitants still exists, and there is a definite psychological component to the syndrome. Let's now focus on initiating drug therapy. Initial therapy is focused on establishing a therapeutic relationship and mapping out a long-term strategy. This provides the patient with knowledge regarding the disease process and lets the patient know that improvement may be a slow process, taking many months. Patients with mild symptoms may be responsive to dietary and lifestyle changes, as shown in box 30.9. Assessing the diet for potentially offending substances and removing those substances may improve symptoms. These substances may be lactose, caffeine, beans, cabbage, fatty foods, or alcohol, according Simran in 2001. In a 1998 study, Versa and colleagues showed a positive correlation between irritable bowel syndrome and lactose intolerance, female sex, and abdominal pain in childhood. A 2-week trial of a lactose-free diet is worth pursuing. Aspartame, an artificial sweetener found in many soft drinks and diet foods, may also provoke diarrhea. Trial elimination may also be worthwhile, especially in diarrhea-predominant irritable bowel syndrome. However, with most irritable bowel syndrome therapies, the placebo effect is often just as successful as the therapy itself. Maintaining a daily diary of food intake, bowel patterns, and emotional stressor can be helpful in the treatment of irritable bowel syndrome. It serves to identify factors that can be addressed and evaluates the effectiveness of treatment. Lifestyle modification requires the patient to understand the stressor in his or her life and the effect these stressors have on physiologic functions. Identifying ways to reduce stress can be critical to improving irritable bowel syndrome symptoms. Biofeedback can be used to decrease gut sensitivity, along with relaxation tapes to decrease stressor. Verne and Serda, in 1997, and Daly and colleagues in 2008, showed some benefit of regular exercise in reducing stress and improving bowel transit. However, as previously discussed in the section on constipation, exercise has little benefit on bowel transit time. Pause the video and carefully scrutinize box 30.9 summarizing dietary and lifestyle changes before proceeding to the next slide. Next we will discuss goals of drug therapy. The pharmacologic agents used for irritable bowel syndrome are the same as those discussed in the constipation and diarrhea sections of this chapter. The goal of pharmacotherapy for irritable bowel syndrome is to alleviate or control the specific symptoms. Generally, clinical trials have been inadequate to establish a definite link between administration of specific drugs and relief of symptoms. In patients with irritable bowel syndrome, between 50% and 75% still have symptoms after 5 years. Response rates to a placebo can be as high as 70%, according to Carlson in 1998, and according to Mertz in 2003. Let's now look at bulk-forming laxatives. Previously, administration of dietary fiber in the form of a bulking agent was commonly the first agent prescribed in irritable bowel syndrome, as shown in Table 30.7. However, administration of fiber to patients with irritable bowel syndrome has become controversial. While the hypothesis exists that fiber increases colonic transit time and therefore lessens colon wall tension and ultimately abdominal pain, clinical trials on the use of fiber in irritable bowel syndrome have had small sample sizes and have been short in duration. Also, fiber can exacerbate the diarrhea component of irritable bowel syndrome. This led the ACG task force to conclude that fiber is no more effective than placebo and is not recommended for the treatment of irritable bowel syndrome. Let's now shift our focus to the hyperosmotic laxatives. When the patient requires a laxative, it is preferable to administer one that is osmotic. See Table 30.7. These agents can work either as a disaccharide sugar, which produces an osmotic effect in the colon, resulting in colonic distension and promotion of peristalsis, or by an osmotic effect in the small intestine, drawing water into the lumen and softening the stool. Lactulose or sorbitol, disaccharide sugars, can be used for patients with predominant constipation. Polyethylene glycol 3350, marketed as Mira-Lax, is a glycolated laxative that can be safely used for a long period without adverse pharmacologic effects. We will now talk about the contraindications to the use of hyperosmotic laxatives. The same contraindications exist as when using these agents to treat chronic constipation. Lactulose is contraindicated in patients who must restrict their galactose intake and in patients with appendicitis, acute surgical abdomen, fecal impaction, or intestinal obstruction. Caution must be used with administration to diabetic patients because of sugar content. Other osmotic agents such as magnesium hydroxide, marketed as milk of magnesia, or magnesium citrate, marketed as Citrama, can be used to promote defecation. Approximately 15% to 30% of the magnesium in these agents may be absorbed systemically. Therefore, caution needs to be used in patients who have renal failure and a decreased ability to excrete magnesium. Adverse events of hyperosmotic laxatives. When taken appropriately, these agents are well tolerated. The most common adverse events are abdominal cramping or nausea. Extensive, long-term use of these agents can lead to laxative dependence. Next we will discuss stimulant laxatives. These laxatives vary in effects, but act by increasing peristalsis through a direct effect on the smooth muscle of the intestines and by simultaneously promoting fluid accumulation in the colon and small intestine. Because of the irritating effect of the agents on the musculature, these agents should be avoided in long-term treatment. Stimulant laxatives include Bisacodil, marketed as Dulcolax, and Senna concentrates, marketed as Senocot, or Senocot S. As with other laxatives, stimulants are contraindicated in patients with appendicitis, acute surgical abdomen, fecal impaction, or intestinal obstruction. Rectal fissures and hemorrhoids can be exacerbated by stimulation of defecation. Action begins 6 to 10 hours after oral administration and 15 minutes to 2 hours after rectal administration. See Table 30.7. These agents are not as well tolerated as osmotic laxatives or bulking agents because of their side effects, which include nausea, vomiting, and abdominal cramping. These side effects can be more severe with cases of severe constipation. Long-term or excessive use can lead to laxative dependence. Several over-the-counter products use the brand name of Dulcolax. One has the main ingredient of Bisacodil and another is docusate sodium, which is a stool softener. This could be important, especially when the patient has been instructed to use the drug as bowel preparation for a gastrointestinal study. And now we will look at surfactant laxatives. This class of laxatives reduces the surface tension of the liquid contents of the bowel. Ultimately, this promotes incorporation of additional liquid into the stool, forming a softer mass, and promotes easier defecation. Examples of this class include docusate sodium, marketed as Colus, or Dulcolax, and docusate calcium, marketed as Surfac. This is the laxative of choice for patients who should not strain during defecation. However, emollient laxatives only prevent constipation. They do not treat it. Administration of emollient laxatives concomitantly with mineral oil is contraindicated because of increased absorption of the mineral oil. Action with these agents usually occurs in 1 to 3 days. The practitioner should consider this class for prevention purposes, not for acute treatment. See Table 30.7. These agents are extremely well tolerated when used to prevent constipation. Side effects include mild abdominal cramping, diarrhea, and throat irritation, but these are infrequent. And now we will focus on antidiarrheal agents. Antidiarrheal agents for patients with IBS with predominant diarrhea can be used on an occasional basis. See Table 30.7. Loperamide hydrochloride, marketed as Imodium, inhibits peristaltic activity, thereby prolonging transit time, and it can increase anal sphincter tone. Approximately 40% of the drug is absorbed from the gastrointestinal tract and 75% is metabolized in the hepatic system. Excretion is primarily in the feces. As previously discussed, the drug does not cross the blood-brain barrier into the CNS. Because of these properties, it is the preferred agent for treating diarrhea. Conversely, diphenoxylate hydrochloride with atropine, marketed as Lomotil, is an opiate similar to meperidine that increases smooth muscle tone in the gastrointestinal tract, inhibits motility and propulsion, and diminishes gut secretions. It is absorbed orally and extensively metabolized by the liver. It can affect the CNS, and atropine has been added to discourage abuse. Neither of these antidiarrheal agents should be used in a patient suspected of having diarrhea from pseudomembranous colitis or ulcerative colitis, or diarrhea resulting from poisoning or microbial infection. Diphenoxylate hydrochloride is contraindicated in patients who are hypersensitive to atropine or meperidine and patients with hepatic impairment. The atropine in Lomotil may aggravate glaucoma in patients with this disease. For additional discussion of contraindications and adverse events, see the diarrhea section. Pause the video and carefully scrutinize Table 30.7 summarizes an overview of selected agents used to treat irritable bowel syndrome before proceeding to the next slide. Pause the video and carefully scrutinize Table 30.7 summarizes an overview of selected agents used to treat irritable bowel syndrome before proceeding to the next slide. Pause the video and carefully scrutinize Table 30.7 summarizes an overview of selected agents used to treat irritable bowel syndrome before proceeding to the next slide. And now we will shift gears to antispasmodic agents. Treatment for patients with postprandial abdominal pain may require the use of antispasmodics. See Table 30.7. However, the efficacy of these medications remains unproven in controlled studies. The presumed desired action is by direct relaxation of the smooth muscle component of the gastrointestinal tract. These agents competitively block the effects of acetylcholine and muscarinic cholinergic receptors that mediate the effects of parasympathetic postganglionic impulses. Examples of commonly used anticholinergics are dicyclamine hydrochloride, marketed as Bentyl, and hyoscyamine sulfate, marketed as Levbid, or Levsin SL. Less commonly used are the belladonna alkaloids, marketed as Donatal, and Cladinium, Librax. Dosing of the anticholinergics is variable and general side effects are associated with the anticholinergic actions. We will now discuss contraindications to the use of antispasmodic agents. These agents are contraindicated in patients who have glaucoma, stenosing peptic ulcer, chronic obstructive pulmonary disease, cardiac arrhythmias, impaired liver or kidney function, and myasthenia gravis. Caution should be used in patients with hypertension, hypothyroidism, and benign prostatic hyperplasia. And now we will discuss the adverse events of antispasmodic agents. Side effects include dry mouth, altered taste perception, nausea, vomiting, dysphagia, blurred vision, palpitations, and urinary hesitancy and retention. Anticholinergic side effects can be used as a measure of titration to achieve the desired pharmacologic end. It is important to monitor for signs of drug toxicity. CNS signs resembling psychosis, accompanied by peripheral effects that include dilated, non-reactive pupils, blurred vision, hot, dry, flushed skin, dry mucous membranes, dysphagia, decreased or absent bowel sounds, urinary retention, hypothermia, tachycardia, hypertension, and increased respiration. Next we will focus on antidepressants. Antidepressants as a class have also been used in the treatment of irritable bowel syndrome. It is not clear whether these agents work by improving a concomitant depression or by improving the anxiety and stress often associated with irritable bowel syndrome. Initial work was done with use of the tricyclic agents such as imipramine, marketed as tofranil, desipramine, marketed as norpramine, and amitriptyline, marketed as Elavil, in patients with severe symptoms. Careful monitoring is important when tricyclic antidepressants are given to patients with irritable bowel syndrome in which constipation predominates, because these agents can cause constipation. Newer agents in the selective serotonin reuptake inhibitor, abbreviated as SSRI, class may also prove beneficial. It has been suggested based on current investigations that antidepressants alter perceived pain thresholds, which are often abnormal in patients with irritable bowel syndrome. See Chapter 40 for further discussion of these drugs. Next we will look at serotonin 3 receptor antagonists. A newer class of drugs has evolved to address the brain-gut neurotransmitter 5-HT3 and 5-HT4 connection with regard to colonic transit time. Currently there is only one drug in this class. The serotonin 3 receptor antagonist in animal models has been shown to decrease abdominal pain, slow colonic transit time, increase rectal compliance, and improve stool consistency. Alozatron, marketed as Lotronex, was initially marketed in 1999, but pulled from the market in November 2000 by the U.S. Food and Drug Administration, FDA, due to concerns regarding ischemic colitis and severe constipation. Alozatron is available only through providers who have officially signed with the pharmaceutical company, FDA, 2002, and is indicated for patients who have diarrhea and no constipation. Let's now discuss chloride channel activators. Initially approved for chronic constipation in 2006, lubiprostone became approved for irritable bowel syndrome in 2008 at a lower strength. It is only approved for women with IBS-C. This was the best replacement for tegaserad, which was taken off the market in 2007. Next we will discuss contraindications to the use of chloride channel activators. Lubiprostone is contraindicated in patients with potential mechanical obstruction or hypersensitivity to components of the product. And now we will look at the adverse events of chloride channel activators. The side effect profile is similar to usage in chronic constipation. However, only gastrointestinal effects are noted. Nausea is the most common side effect of lubiprostone. The rate of nausea is dose-dependent and was experienced by approximately 8% of patients. Other common gastrointestinal side effects include diarrhea, abdominal pain, and abdominal distension. We will now focus on the interactions chloride channel activators. No drug-drug interactions have been discovered with lubiprostone. In vitro studies showed the cytochrome P450 isoenzymes are not inhibited by the drug. Next we will discuss selecting the most appropriate agent. The emphasis in the care of patients with irritable bowel syndrome should be multidimensional. Irritable bowel syndrome can present in many stages: mild, moderate, or severe. Selection of the most appropriate drug therapy should be based on the presenting symptoms. Each case needs to be evaluated, and treatment should be individualized. Figure 33 and Table 30.8. We will now focus on first-line therapy. First-line therapy is selected based on the presenting symptoms. Qualitatively, Patients often feel the burden of this disease, but believe this is not appreciated by primary care providers and specialists. Pharmacologic agents need to be considered only when an exacerbation of the disease occurs. Constipation predominant irritable bowel syndrome can be treated with an osmotic laxative on a long-term basis without adverse effects. Antidiarrheal agents are preferred in patients with diarrhea predominant irritable bowel syndrome. Loperamide is the preferred agent because it causes the least CNS activity and has the added benefit of improving anal sphincter tone. As with any chronic syndrome, use of low-level antidepressants may be helpful for symptom control. With the additional problems of pain, gas, and abdominal bloating, a trial of an antispasmodic may relieve symptoms. Dicyclamine is the agent of first choice because of its shorter half-life, which may minimize the anticholinergic side effects of the class. Psychological symptoms associated with irritable bowel syndrome may be treated by antidepressants. Selection of an antidepressant should be based on the specific symptoms of depression, stress, or anxiety. The SSRIs are the most commonly selected agents because of their safety profile and efficacy. Next we will discuss second-line therapy. Unresolved complaints of predominant diarrhea can be treated with diphenoxylate hydrochloride, which has a longer duration of action, but can be addictive because of its opioid properties and should be reserved for short-term use. For postprandial abdominal pain, gas, and abdominal bloating, longer-acting antispasmodics such as hyoscyamine sulfate can be considered. The second-line choice for psychological symptoms is the tricyclic antidepressants. These agents have more side effects than SSRIs. Let's now switch gears to third-line therapy. The use of stimulant laxatives in cases of constipation predominant irritable bowel syndrome should be reserved for more resistant cases, but these agents should be used with caution. They should not be used for long periods, and they can aggravate abdominal cramping. The older anticholinergics such as the belladonna alkaloids and clodinium should be used very sparingly for postprandial abdominal pain, gas, and abdominal bloating because they produce more intense anticholinergic side effects. Pause the video and carefully scrutinize Figure 33, which is a treatment algorithm for irritable bowel syndrome, before proceeding to the next slide. Let's now progress to special considerations. We will begin with the pediatric population. Children with crampy abdominal pain, constipation, or diarrhea present a challenge to the practitioner. Although these symptoms sound like irritable bowel syndrome, there are no established criteria for children. As previously discussed, some experts think that these children may acquire irritable bowel syndrome later in life. Treatment for these symptoms can include some of the same approaches of increasing fiber and use of antidiarrheal agents and the newer antispasmodics. Close follow-up is an important aspect of care. Next we will discuss the geriatric population. Initial presentation of irritable bowel syndrome in people older than age 50 is rare. Abdominal pain in older patients should be considered a more ominous symptom, unless they have been previously diagnosed with irritable bowel syndrome or spastic colon, a version of colitis. Older patients may report a long-standing history of bowel trouble with any of these diagnoses. And now we will look at the women. In Western society, women are more likely to have irritable bowel syndrome and to seek care. A history of verbal or sexual abuse may also contribute to irritable bowel syndrome. Women have surgery more often when the origins of abdominal pains are unclear. Pause the video and carefully scrutinize Table 30.8 summarizes the recommended order for treatment for irritable bowel syndrome before proceeding to the next slide. Next we will focus on monitoring patient response. Monitoring the patient's response to therapy should take place within 3 to 6 weeks of the initial evaluation. For patients with mild symptoms, the initial treatment includes working with the patient regarding dietary and lifestyle changes, education about the disease process, and reassurance about lack of organic causes. Patients with intermittent symptoms require the same initial approach, but addition of pharmacologic therapy can prove helpful, if only for the placebo effect of the drugs. Psychological counseling may also be helpful with these patients. Severe irritable bowel syndrome requires all of these interventions and the addition of intensive psychotherapy. Patients with mild to intermittent symptoms can easily be managed in the primary care office with close monitoring initially, every 3 to 6 weeks, and then more routine care. Irritable bowel syndrome is a disease of exacerbations and remissions, but up to 70% of patients respond to treatment within 12 to 18 months. Those with a shorter duration of symptoms and fewer psychological symptoms have a better prognosis. Referral to a specialist should occur when there is no relief with any therapies, or when the patient has atypical symptomatology. Some patients do not respond. Continued symptoms rarely need a reappraisal of the diagnosis, but appropriate testing should be performed. We will now briefly talk about patient education. Patient education needs to cover dietary modifications, psychological stresses, and lifestyle changes. Begin by acknowledging the patient's fears and concerns and show that you take them seriously. According to current evidence-based research, patients can be reassured of the absence of organic disease based on the history and physical examination. The patient should be informed that this is a chronic disease and that initiating drug therapy does not lead to cancer, colitis, or an altered life expectancy. Making the necessary dietary changes can be crucial for symptom relief, especially with mild symptoms. A multidisciplinary approach is often the best method of care, using the services of a dietitian and psychological counselor. Next we will shift our focus to drug information. A variety of drugs are available to help control symptoms, and most have minimal side effects. However, the drugs need to be used in conjunction with stress relief techniques, identification of influencing factors, and education about the disease to help provide an improved quality of life. And now let's talk about patient-oriented information sources. Many resources exist for patients with IBS. One of the most comprehensive resources is the ACG, which covers many topics on GI health. The International Foundation of Functional Bowel Disorders also has a comprehensive website with resources for both patients and healthcare providers, as shown in box 30.10. And now we will look at nutrition or lifestyle changes. A major focus of caring for patients with irritable bowel syndrome is helping them assess their diet, making adjustments as necessary. A trial of removing lactose foods from the diet poses no risks to the patient and may have a benefit if it relieves symptoms. And finally, pause the video and carefully scrutinize box 30.10 summarizing patient resources for irritable bowel syndrome. Next we will discuss sinusitis. Sinusitis is an inflammation and/or infection of the paranasal sinus mucosa. The term rhinosinusitis is used by some specialists because sinusitis typically also involves the nasal mucosa. The majority of these infections are viral in origin, nevertheless, antimicrobials are prescribed frequently. It is thus important to differentiate between viral and bacterial sinusitis to aid in optimizing treatment decisions. Viral sinusitis and bacterial sinusitis are difficult to differentiate because the clinical presentations are similar. Viral infections, however, tend to resolve by 7 to 10 days. Persistence of symptoms beyond this time likely indicates a bacterial infection. Bacterial sinusitis can be categorized into acute and chronic disease. Acute disease lasts less than 30 days with complete resolution of symptoms. Chronic sinusitis is defined as episodes of inflammation lasting more than 3 months with persistence of respiratory symptoms. Sinusitis is diagnosed more frequently in children than in adults. Typical clinical presentation and diagnosis of bacterial sinusitis are illustrated in Table 107-4. Between 5% and 13% of viral upper respiratory tract infections in children are complicated by bacterial sinusitis, whereas only 0.5% to 2% of viral upper respiratory tract infections in adults are complicated by sinusitis. Factors associated with the development of bacterial sinusitis include viral respiratory tract infections and, less commonly, allergic inflammation. Other factors that can be associated with sinus disease include systemic diseases, trauma, environmental exposures, and anatomic abnormalities.